Welcome to In the Thick of It from the HCM Society, a show that dives deeply into hypertrophic cardiomyopathy with leading experts in the field. We explore groundbreaking research, new approaches, and other exciting topics. Please enjoy today's discussion supported by an unrestricted educational grant from Bristol Myers Squibb. Hello, everybody. Welcome to the In the Thick of It podcast. My name is James MacNamara from the University of Virginia, and I'm pleased to be joined today by Sharlene Day, Professor of Medicine and the Director of Translational Research at Penn. And we're going to have another in our series of kind of meet the trialists. We're going to talk about the SONATA trial. And I'd just first like to welcome you to the podcast, Sharlene, and could you tell us a little bit about the trial?
Yeah, I would love to. So the SONATA trial is a double-blind, placebo-controlled clinical trial testing the safety and efficacy of sotagliflozin, which is a dual SGLT1 and 2 inhibitor in patients with hypertrophic cardiomyopathy. The trial is being conducted across multiple countries, so it's 130 sites total in 20 countries, and will seek to enroll 500 patients. The trial is enrolling patients both with obstructive and non-obstructive hypertrophic cardiomyopathy, as long as they have symptoms, with an inclusion criteria of a Kansas City Living with Heart Failure Questionnaire score, clinical summary score of less than 85. So the trial duration is 26 weeks, and the primary endpoint is the change in the KCCQ clinical summary score over that 26-week period, from baseline to 26 weeks after randomization. The patients, as I mentioned, patients with obstructive HCM and non-obstructive HCM are eligible. And I think that's a unique feature of the trial, because most of the recent trials, particularly those in cardiac myosin inhibitors, have focused on one group or the other. I think we'll get into that rationale in a little bit. And then the patients need to be NYHA class 2 or 3 and have an ejection fraction of at least 50%. Or 55% if they're on a cardiac myosin inhibitor.
Yeah, that's fantastic. And the trial is actively enrolling.
Yes.
From what I hear, everything's going pretty well on that regard.
Yeah, we are, of the 500 patients, we're getting close to 200 patients randomized. So, and it is on the pace, the expected pace. We're staying right at the predicted accrual. And if we stay on that pace, we should have completed enrollment by May of 2026.
Oh, awesome. All right. So both going well and some time for interested people to hop on board. Well, I'd love to talk to you, and delve into the SGLT1 and 2 inhibitors. It's a drug that, and I think most of the audience is going to be familiar from the heart failure space and some of the diabetes space. But, I'd love to hear kind of your rationale. What do we know about these drugs in HCM?
Well, they've never been tested in HCM before, so this is the first trial to do that. I mean, just in reference to the distinguishing sotagliflozin from other SGLT2 inhibitors, I'll just kind of give you a little bit of background there. So sotagliflozin is less selective for SGLT2 than the others, like empagliflozin, dapagliflozin. So it does inhibit SGLT1 as well. So as you know, SGLT2 is only expressed in the kidney, whereas SGLT1 is expressed in other organs, including the intestines, and also at a very low level in the heart. So it's possible that it could have an on-target effect in the heart that the SGLT2 selective inhibitors would not have. So, we don't yet know how these drugs are conferring their beneficial cardiovascular effects in heart failure yet. So, we certainly, don't know whether those effects will extend to HCM. That's sort of part of the trial. But we're the rationale for designing the trial in the first place and to test sotagliflozin was based on the fact that there is obviously are sort of overlapping sort of etiologies or mechanisms, of heart failure in patients with HCM that's more similar to heart failure with preserved ejection fraction, the majority of patients, having to do with diastolic dysfunction and probably also cardiometabolic factors, right, that are contributing to the symptom burden in patients with HCM. But for a minute, getting back to the distinguishing the 1-2 inhibition from 2 inhibition, I think largely there are going to be many class effects, and you've seen this in heart failure, where sotagliflozin and EMPA and DAPA have all have beneficial effects in heart failure and reducing mortality and heart failure hospitalizations. I think the one perhaps outcome that is different with the sotagliflozin trials versus the other SGLT2 inhibitor trials are that sotagliflozin also lowers ischemic events. So that would be include myocardial infarction as well as stroke. And that may have to do with inhibition of SGLT1 and platelets. So the sotagliflozin does inhibit platelet aggregation and activation, which is not true of the others. So that's one area in which it's distinguished in existing clinical trials. We don't yet know, what the effects are going to be in HCM at all, right? And that's why we're doing the trial. But I would say the other distinguishing feature is, in addition to the SGLT1 inhibition, is that sotagliflozin is more hydrophobic. And so its dwell time in a membrane, in whatever membrane it's, whatever sort of transporter or receptor it's targeting, is going to be longer than it is for the SGLT2 selective inhibitors. And so that may be, a potential benefit of SOTA over the others. We don't yet know, but that's one possibility.
That's really interesting. I didn't realize that with soda. I'm very interested in the ischemic side that you mentioned because we know ischemia is likely part of the pathophysiology of HCM. It's probably not platelet mediated. But do you think, and I'm going to ask you to speculate because I know we don't know. Do you think there's a chance that it could reduce the ischemia during exertion and physical activity that we will
It's
see in
possible. I mean, we're not really testing that in the trial per se. We don't have endpoints for ischemia, and we're not doing stress tests or cardiopulmonary exercise testing in the study. We're really basing this on fairly
yeah, they
conclusively in
feel.
terms of the primary endpoint is in patient-reported outcomes. We have secondary endpoints, but nothing that's directly addressing ischemic endpoints. And I'm not sure if it would be, microvascular ischemia is probably not platelet driven, but
I'm curious, what are some of the secondary endpoints that you're particularly keen in seeing the effect on?
yeah, they're kind of the usual, right? For, as we've seen in other HCM trials, so NYJ classification, echo endpoints. We were interested in terms of a safety endpoint in terms about obstruction, right? Because these drugs do cause at least a transient diuretic effect. So you could, in theory, increase outflow tract gradients in patients. We haven't seen any adverse events related to that yet. Obviously we have to analyze the data once the study's done, unblinded, to see whether there's been any increase in gradients, but we certainly haven't seen any serious adverse events that have arisen so far. And then, we have the usual, again, biomarkers, BNP and troponin, high sensitivity troponin I, as well as a few other patient-reported outcomes in addition to the KCCQ. So, we designed this to be a low burden study and, decided, we had cardiopulmonary exercise tests in sort of earlier iterations that were smaller studies. And ultimately, for a couple of reasons, decided not to do it. One is we thought it would make it more broadly applicable and also be able to include sites that wouldn't have that capability. And I think, as you and I have discussed before, I'm not sure that using peak VO2 as the primary endpoint that number of trials have used, I think you can see a change if you do an exercise intervention, right? Where you would be expecting to see an increase in exercise capacity. Or if you're increasing cardiac output, like in obstructive patients where you're relieving the outflow tract obstruction. But I'm less sure that the traditional cardiopulmonary exercise test endpoints are going to really be a reflection of the benefit of some of the pharmacologic interventions, including the sodium glucose transport inhibitors.
Yeah, and certainly we've seen mixed results with both functional, 6-minute walk test and peak VO2 in the HFpEF population. I'm thinking particularly
Yeah.
with Barry Borlaug's
Mhm. Yeah.
dapagliflozin trial. Though they didn't really do upright CPET testing, I'd still be interested to see what happens if they did. But they didn't see a change in peak VO2, and the data's been kind of all over the place in
Yeah.
heart failure with 6-minute walk. So I
Yeah.
think the targeting the feel part of feel and function certainly does make sense. I'm glad you brought up the obstruction because that was something I wanted to ask you specifically about because it is a unique aspect of this trial is
Yeah.
that it's kind of an all-comer HCM. I'm trying to think of another trial we've had that way. What is the protocol to kind of monitor levels of obstruction
Yeah.
with um
Right.
with
So
yes, obstructive patients?
yeah, so I mean, in terms of the safety endpoint, we built in an echo at the 4-week time point after randomization. And so that really is the primarily to make sure that we weren't seeing, a large rise in the gradient, which as I said, we're blinded, but but we haven't seen any serious adverse events or withdrawals for that reason.
Yeah, no
Um,
news is good news at this
yes,
stage.
that's what I'm anticipating, but that was built in for that reason. But also that, the diuretic effect is pretty transient. And that's kind of what we're hearing from patients too. If those who do experience something, that could be a drug related side effect in terms of the, increased urination, weight loss, and diuresis. Generally, that sort of balances out after, a few weeks. And so, we're not anticipating that it's going to be an issue. But really, the rationale for enrolling patients with obstruction and without obstruction had more to do with the fact that the mechanism of these drugs would be independent of gradient, right? This is not going to be an intervention that lowers gradient. And so, obviously, for patients who are, in need of gradient reduction therapy because they have symptoms that are clearly linked to severe outflow tract obstruction, those would not be patients we would enroll in the study, right? And so, that's part of the exclusion criteria. If they are going to be undergoing advanced gradient reduction therapy, either with a CMI or with septal reduction therapy, they would not be eligible to participate. But, as there are a number of patients that have, moderate gradients who have some symptoms. It's not really clear if they're related, or you've lowered their gradients before and it hasn't helped them. So those are the types of patients, the obstructive patients who we'd be enrolling in this study.
And remind me, are you enrolling patients who are stable on CMIs but are having residual symptoms?
Yes. So patients who are on currently just mavacamten, but eventually aficamten when it gets approved, as long as they're on stable dose, so they're not being dose titrated, and their ejection fraction is at least 55%, because we want to have a little bit of a buffer so that we wouldn't have interruption of therapy in the middle of the trial. And as long as they're still symptomatic and their KCCQ is 85 or below. And they can either still have residual gradients but not be going for septal reduction therapy, or they can have no gradient but still be symptomatic.
Okay. Yeah, that makes a lot of sense. And it kind of leads to the my last question, which is, what do you think for the people listening, if they're either in the, they're a site in the trial or they have a referral source to the site in the trial, what kind of a patient should we think about, in day-to-day practice for, you'd benefit, let's get you into Sonata.
Yeah, I mean, the eligibility criteria are quite broad, as we've discussed. So, any patient that fits the eligibility criteria, we would be happy to approach and discuss the trial with. And we would like to enroll broadly. We'd like to have a very representative sample of patients. So, in addition to enrolling at the sites, the Hypertrophic Cardiomyopathy Association has been not enrolling. I'm sorry, has been broadcasting the trial. We did a webinar early on, and and continually sort of lets patients know about existing trials that they may be interested in, so we can recruit from places other than just the primary sites if they're not being seen at a specialty center.
Yeah,
And I think,
absolutely.
one thing that's really interesting, I don't know if you're going to ask me this, but I'm going to tell you anyway, is, the mechanisms of these drugs, I think, are just fascinating. And, we've done a little bit of work in our lab and sort of adjacent labs at Penn, and there's certainly others who've been, working diligently on trying to understand what's conferring the benefit in the heart. Because it's clearly not just the effects on the kidney, right? There have to be something directly in the heart. There's a couple targets that have been proposed. And one thing that we've observed, we've been doing some preclinical studies using human living myocardial slices, is that, yeah, and we get these slices from myectomy samples from patients with HCM who are undergoing myectomy, and then from non-failing hearts. And the HCM hearts, as you would expect, do more work, so they generate more force. And we find that the SGLT inhibitors, sotagliflozin, as well as empagliflozin, reduce the amount of work. It's a lot more modest than you see with mavacamten, but they do reduce the total amount of work, which would make the heart potentially more efficient. But we see that the sotagliflozin does it to a little bit greater extent, particularly at high afterloads when we set the rig to impose a higher afterload. So I think that there's a potential mechanism there that would be, really beneficial in HCM. And then there's also, probably another mechanism around metabolism. And there may be a direct metabolic target there that improves the way that the heart uses fuel. And that would be beneficial really across a spectrum of cardiomyopathies where cardiac metabolism is impaired.
Yeah, is that the ketone body theory that it shifts it more to ketone metabolism?
Yeah, I think, that's what we originally started with. But I actually think the effects are totally distinct from ketones. And we've tested this with the human living myocardial slices, that the effects of ketones actually greatly increase work. And so we don't think that's how the SGLT2 inhibitors are working. But I
How
think
did
they
they,
may be through.
or what's that signal for shifting metabolism? Because yeah, the ketone body was, I mean, it
Yeah.
feels, that was 10 years ago. We've been talking about these drugs for a long time.
Yeah. Yeah.
But I remember, we were doing our work in HFpEF. We were looking at that and trying to measure it, and we weren't successful. We focused on exercise and the
Yeah.
invasive hemodynamics,
Yeah.
play to your strength.
Yeah.
But what would be what's kind of the current thinking for metabolism?
I don't know. I mean, the observation has been that the heart increases uptake of multiple fuels, that it's not just a singular fuel, right? And that would increase the metabolic flexibility. And I think the exact target is still being pinpointed. We have somebody at Penn who's working on this that has a preprint, hasn't been yet published, and they're still, still working on it. So, but I think it's fascinating. I think these are going to have pleiotropic effects, right? It's not going to be a single target in a single organ, right? So it's kind of interesting because it's kind of going backwards, right? Where you have a clinical observation that was unexpected, and then you try and figure out why, rather than doing something in a lab and saying, "Oh, this seems to do this. Let's test it in the clinic." So
Yeah, that has been the story of the SGLT2 inhibitors is
yeah,
they keep winning in trials and we don't really know why, but we have lots
right,
of many possible reasons.
exactly.
But as long as they keep winning, and hopefully we'll see this as one of the next treatments in hypertrophic cardiomyopathy. I think we are out of time, so I want to say thank you for coming on board. For the audience, this is Sharlene Day. We're talking about the SONATA trial, which is a double-blinded clinical trial for sotagliflozin in both obstructive and non-obstructive HCM. If you have patients that are interested, there are sites all over the world that are enrolling in the trial, and it sounds like they'll continue to enroll through the first half of next year. Charlene, thank you so much for joining us, and thank you everybody in the audience for listening to the In the Thick of It podcast.
Yeah, and please don't hesitate to reach out to either myself or to Carolyn Ho, who's the co-chair of the steering committee for SONATA. We'd be happy to answer any questions.
Fantastic. Thank you.
Thanks for joining us on In the Thick of It, presented by the HCM Society. Make sure to subscribe to our show for more expert insights into the field of hypertrophic cardiomyopathy. For more information, check out the links in our show notes. We hope you will join us again for our next episode.